Hello everyone. This is a small presentation on pharmacovigilance. Yes. So I'll just give some basics about pharmacovigilance and drug safety today. Now let's see what is pharmacovigilance. Pharmacovigilance is defined as the science and activities which are related to the detection, assessment, understanding, and prevention of adverse effects or any other drug related problem. So, in short, it is a science of adverse drug reaction monitoring. Let's see some definitions. Adverse effect. Adverse effect is any undesirable effect in patients that is seen during the use of a medicine or which is suspected to have been caused by the drug. For example, suppose somebody is taking a medicine and he has a fall from the stairs. It has to be documented as an adverse effect. Though there is no direct link between falling from the stairs and the medicine, but it might have been caused either due to the effect the drug might have caused on the CNS of the patient, which has to be looked into later. So, adverse effect is anything, any undesirable effect that happens in patients while they are on medication, or which is suspected to have been caused by the drug. Whereas adverse drug reaction, as per WHO, is a noxious and unintended response at doses normally used for prophylaxis, diagnosis, or therapy of diseases, or for the modification of physiological function. Now, what is the difference between adverse drug event and adverse drug reaction? Adverse drug event is what we have just observed as happened while taking the medicine, yet has to be proved that it is because of the drug. So that means there is no causal relationship yet established between the drug and the reaction at this juncture. Then it is called as adverse drug event. Now, once the causal relationship is established or it is suspected that the reaction might have been caused or is caused, likely to be caused by the drug, there are some scales, which determine that. Once it is established, then the adverse drug event is known as adverse drug reaction. Now, what are serious adverse event? Now, this is an important medical event as the result in congenital abnormalities or birth defects. So you can see this child, you can see this is, I'll be explaining about this in the next few slides. Or it also may cause significant disability or incapacity. The reactions may cause hospitalization or prolongation of existing hospital stay, or it may cause life-threatening situations or death. So you can see one reaction in this picture, whereas this reaction is known as Stevens-Johnson syndrome, and it can be caused by fluoroquinolines like ciprofloxacin also. It can be caused by that. And unexpected ADRs are those ADRs whose nature, intensity, or incident it falls outside the information that is provided in the investigator's brochure or package insert or monograph of the marketed drug. So, for example, we all know that antihistamines cause drowsiness or some antibiotics cause diarrhea. So, some things are known, and because they would have either been listed in the package insert or it has been given in the literature or some such thing. But something that is happening outside of this, which is totally unexpected, falls under unexpected ADR. Some alarming facts about ADRs are some ADRs can cause permanent disability or death. See, in the picture, you can see the skin peeling off. This reaction is very severe. It can lead to death, and drugs like phenytoin can cause this. Carbamazepine can cause this. Very rarely, of course, it's not a common occurrence, but it can be caused by few drugs. And example is toxic epidermal necrolysis. And ADRs are reported to be the fifth leading cause of death. ADRs account for 3 to 15% of all the hospital admission in the USA. Such a data is not yet available in India, and we are collecting the data. We are in the process of data collection and then coming into these values, percentages. And the incidence of ADRs is highest in the elderly and special population. Elderly because they're taking many drugs. Polypharmacy is prevalent there. Special population because they are not included in the clinical trials. So, see, pregnant women are not included, infants are not included, geriatric population is not included in the clinical trials. So, we do not know what kind of reaction these drugs can cause on them. When actually the drug hits the market and these consumers take it, then some reactions which are we can actually observe some reactions which can be dangerous. And 6 to 7% of hospitalized patients they experience serious ADRs, and at least 50% of the ADRs are preventable if we take care. ADRs have been reported to increase the length of hospitalization as well as they increase the hospital cost. Next, why pharmacovigilance? Pharmacovigilance, as I told you, it's a science of adverse drug reaction monitoring. So, why should we monitor? Why should we bother about ADRs? The fundamental thing is humanitarian concerns. So we have to know because it can be mild like rashes to toxic epidermal necrolysis or some other Stephen Johnson syndrome which can be life threatening. So we have to protect the human being. So humanitarian concern comes first. And the ethics in pharmacovigilance is if you know that something is harmful to another person, we have to tell. Not telling is unethical. So if you find that a certain reaction has been caused by a certain drug, it has to be reported. Then only we can prevent the others from experiencing the similar adverse drug reaction. Second major reason is economical concern. As I told you in my previous slide, the it increases the hospital expenses because as it is, the patient has to pay for his healthcare expenses. Apart from that, if an ADR occurs, some more money will be spent on management of this ADRs, and it is very difficult for a patient in an developing or just developed country like India. Then third most important reason is for regulatory decisions. See, if you know that some reactions are caused, it can be discussed at the regulatory body by the regulatory body, and that warning or symptom can be incorporated in the in the product information leaflet. Or even in some cases, if it is severe, decisions about drug banning also can happen. So, but if there is no documentation about the ADRs, regulatory decisions cannot be taken and patients keep suffering. So it becomes very important for regulatory decisions. Now, coming to pharmacovigilance and drug safety, all of us should know that every drug is associated with risk. There is no drug which is completely safe, and pharmacovigilance helps to assess the risk associated with the drug. Now, for a medicine to be considered safe, its expected benefits should be greater than the associated risks. It's basically a question of risk versus benefit. And pharmacovigilance helps to obtain a comprehensive safety profile of any medicine. Now, what does the history say about the ADRs? So there was an infamous thalidomide disaster in the late 1950s and early 1960s when thalidomide was used in about 46 countries by pregnant women for morning sickness. And then it resulted in the biggest disaster ever in the world, with more than 10,000 children born with a range of severe deformities. See, I showed you a picture that time, even this picture you can see. So this was the first time, people came to know. WHO started the international monitoring after this disaster because till then it was not much known that the drugs can cause such serious reactions. So this was one of the milestone in the history of pharmacovigilance, I would say. Then in 1950, chloramphenicol causing aplastic anemia was reported. In 1970, clear cell adenocarcinoma of the cervix and vagina due to the in utero exposure to diethyl stilbestrol, which was 2 decades earlier. The exposure was 2 decades earlier, but the ADR happened later. And in mid 1970, oculomucocutaneous syndrome caused by fractalol 5 years after drug marketing. And in 1980, diclofenac was noted to cause death from liver disease. In 1982, benoxaprofen caused liver disease that was reported. Then rhabdomyolysis from cerevostatin was reported in 2001. Arrhythmias associated with the use of antihistamines, namely terfenadine and astemizole, was reported in the year 2002. And heart attacks from rofecoxib was reported in the year 2004. And many other ADRs which were reported are seizures with tramadol, anaphylactic reactions from vitamin K, liver toxicity from troglitazone, myocardial infarction from sildenafil, then timolol ophthalmic preparation caused many serious episodes of heart block and asthma, resulting in over 10 deaths. Some examples of market withdrawals. Rofecoxib was withdrawn by Merck in the year 2004, then cerevostatin in the year 2001 by Bayer, cisapride in the year 2000 by J&J, and so on. So we have some few examples I have given. Then what is the relevance of PVG? Now, the effect of any medical intervention cannot be predicted with absolute certainty. There is no drug or medical intervention which will not have some negative and some undesirable effect on someone somewhere at some point of time. And information about the rare drugs, because they are rare, it's not at all available in anywhere in literature until they actually happen. Now, what are the reasons for ADRs in clinical practice? One reason could be overprescribing. For example, if paracetamol is prescribed alongside paracetamol and nimesulide combination, obviously the hypothermia will result, which is not at all desirable. Second, self-medication, which is one of the it is most rampant in our country. So self-medication can cause many problems, including ADRs. Then lack of patient education, especially in chronic diseases. Now, for example, a person who is diabetic, let's say, and he should be educated not to take double dose of antidiabetics if he misses a dose. Suppose he misses a dose and he takes 2 tablets of antidiabetic. What happens? It leads to hypoglycemia. So this is also an ADR. Then polypharmacy means using more than 5 drugs. So there are many geriatric population and even comorbid conditions people are having, which because of which we have to use many drugs. So these polypharmacy leads to drug interactions and many other problems, and ADRs can result from that. And polytherapy in a country like ours, not only allopathy, we are using Ayurveda, we are using homeopathy, we are using Unani. So all these drugs, though Ayurveda is considered safe, homeopathy is considered safe, nobody can deny that there is a possibility of interaction between allopathic drugs or Ayurvedic drugs or homeopathic drugs. So this can lead to ADRs. Then non-adjustment of dosage regimen, especially for patients with renal impairment or hepatic impairment, absolutely the dose has to be adjusted. When the dose is not adjusted, it leads to ADRs. And similarly, in extremes of age patients like geriatric patients or children or neonates, the dosage has to be adjusted. If a normal dose is given without adjustment, it leads to ADR. Now, as it is, the documentation of ADRs in this special population is poor because they are not included in the clinical trials. And irrational prescribing, like prescribing antibiotics in viral infections, that is unnecessary use of antibiotics, also causes ADRs. When inappropriate use, double dose when a dose is missed, or non-completion of an antibiotic course or any other anti-TB course, whatever, whichever drug it is, inappropriately if it is used, it leads to ADR. When insufficient monitoring of therapy, for example, anti-TB drugs, they are known to cause hepatotoxicity. So, whenever the patients are prescribed anti-TB drugs, their hepatic function has to be monitored periodically. If this is not done, again it may lead to hepatic toxicity. Similarly, aminoglycosides are known to have renal toxicity. So, renal function needs to be monitored from time to time. Then multiple medical conditions like asthma and hypertension. So those drugs may interact and then they may cause ADRs. And drug-drug interaction, I had an example where a combination of ACE inhibitor and potassium-sparing diuretics such as amiloride can increase potassium retention so strongly that life-threatening hyperkalemia occurs. Then even gender can make a difference. Like women may be at a greater risk of ADRs than their male counterparts. Then AC inhibitors like enalapril may cause birth defects if used in pregnant women. And coming even genetic predisposition also plays a role because personal or family history of ADR may be one reason. There may be certain enzymes responsible for metabolism absent in some people that can lead to ADR if this drug is taken. So, in conclusion, we can say adverse drug reaction monitoring is not only about drugs. In fact, it is about people and it is about saving lives. The ultimate goal of pharmacovigilance is to achieve rational and safe use of medicines and patient safety. So, this is a short introduction for today. I'll be continuing this topic with few more videos. I'll be coming out with few more videos and I'll be sharing. So, thank you so much. Thanks a lot. See you in the next video.